Imagine it's 3 a.m. in a Canadian emergency room. The fluorescent lights buzz softly. The plastic chairs are full of people shifting, coughing, scrolling through their phones, trying to sleep sitting up. A nurse walks past with a clipboard, eyes tired but focused. Somewhere, a monitor beeps. You've been here for 5 hours. You're not dying, but you're not okay. Your chest hurts, or your kid has a scary fever, or your parent fell and can't move their leg properly. You did what you were told. If it's urgent, go to the ER. You look up at the screen, your number hasn't moved. You know the care will be free. There's no bill waiting for you, no credit card required, no forms with out-of-network charges and surprise copays. But what is the cost of time, of uncertainty, of productivity lost, of a healthcare system that works until you need it right now? This video is about that paradox. How can a country with free universal healthcare still feel like it's running on empty? How can the system be both a source of national pride and a source of daily frustration for patients, families, and the people who work inside it? And what happens to a rich country when its healthcare system was built for a smaller, younger, healthier population, but now has to carry something very different? Welcome to Canada's healthcare illusion. Free, but at what cost? Act 1, the promise. How Canada built its healthcare myth. Before talking about breakdowns, it's important to understand the origin story, because the Canadian healthcare model didn't appear out of nowhere. It was built deliberately to solve very specific problems for a very specific kind of society. The post-war idea, picture Canada in the decades after World War II. The population is smaller and much younger. Life expectancy is significantly lower than today. Chronic diseases like diabetes and dementia are less common simply because people don't live as long. Medical technology is basic by modern standards, but there's a problem. People get sick, accidents happen, and paying for care can destroy a family financially. The idea of universal, publicly funded health care was radical at the time. No one should be bankrupted by illness. The solution? A system funded by taxes and public budgets, where medically necessary hospital and physician services are covered for everyone, regardless of income. The brilliance of this model was simple. It pooled risk across the entire population. It removed financial fear at the moment of emergency. It allowed people to seek care without asking, can I afford this? For a mid-20th century country with fewer seniors, fewer chronic conditions, and simpler treatments, this was not just humane, it was sustainable. The brand. At least we don't pay like the Americans. Over time, the healthcare system became part of Canada's identity. It's a line you hear in conversations and see in comment sections. Sure, we have problems, but at least we don't have huge medical bills like in the United States. That comparison became a shield. Any criticism of long waits, crowded emergency rooms, staff burnout, or lack of access could be softened by the idea that things are even worse somewhere else. This is important because it feeds the illusion. On paper, universal coverage exists. At the border, new arrivals are told healthcare is free. In political speeches, it's a symbol of fairness and compassion. But coverage is not the same as capacity. You can have the right to see a doctor. It doesn't guarantee there will be one available. The system's original assumptions. The healthcare model was optimized for a world where the population pyramid was wide at the bottom and narrow at the top. Most serious health events were infectious diseases, accidents, and acute episodes. Hospital stays were shorter, and there were fewer complex long-term interventions. Fewer people lived long enough to develop multiple chronic conditions at the same time. In that world, the key challenge was making sure everyone could get basic, necessary care rather than dealing with extremely high volume and complexity. Canada succeeded at that mission. The question is, what happens when the mission changes? Act 2, the strain. When a young system meets an old population, fast forward to today. The country is older, the population is larger, medical technology is far more advanced and far more expensive. Chronic diseases are common, and expectations have changed. People expect prevention, early diagnosis, mental health support, elective procedures, and a long active retirement. That's a good thing. It's also expensive. The demographic time bomb demography is destiny, and healthcare is where you see that sentence become real. Over the past decades, the share of Canadians over 65 has risen. People are living longer, often with multiple conditions that require ongoing care. Heart disease, diabetes, arthritis, cancer survivorship, dementia. The demand for home care, long-term care, and rehabilitation has exploded. The original system was not built for this. It was built for a world where the average person might have one big health crisis late in life and then die. Today, many Canadians have long health journeys instead of short episodes. Surgery, then rehab, then chronic management. Multiple prescriptions that need monitoring, regular tests and scans, crises that send them in and out of hospital. Every step uses capacity. Doctors, nurses, technicians, beds, labs, imaging machines, social workers, support staff. When you stack millions of those journeys on a system designed for shorter lives and simpler care, you get strain, staffing, the human bottleneck. Bricks and machines don't heal people. People heal people. In every province and territory, you hear the same stories. Nurses working double shifts night after night. Family doctors retiring faster than new ones can replace them. Young doctors choosing specialities or locations based on lifestyle, not just need. Rural and remote communities struggling to recruit and retain any provider, let alone many. This is not because healthcare workers don't care. It's because the math of hours and people is brutal. If the population grows, the share of seniors grows. Care becomes more complex. Paperwork and administrative tasks increase. But the workforce doesn't expand at the same speed. You end up with longer wait times, burnout, more people leaving the profession or cutting hours. A vicious cycle. The more overworked people are, the more they leave, increasing pressure on those who remain. And the illusion is that coverage exists. The reality is that capacity is finite. Wait times. The hidden cost of free. In most cases, Canadians do not receive a bill for medically necessary care, but they do pay with time. Waiting lists and delays are the shadow price of a system under strain. Different kinds of waits show up: waiting to get a family doctor or primary care provider, waiting to see a specialist after a referral, waiting for diagnostic imaging, MRIs, CT scans, ultrasounds, waiting for scheduled surgeries that improve quality of life but are not immediately life-threatening like joint replacements, waiting in the emergency room for hours because every bed is full and staff are stretched. These waits have real economic and human costs: lost working days, reduced productivity, parents missing work to care for sick children, people dropping out of the labor force early because of untreated or undertreated conditions, mental health decline while living with uncertainty and pain. The system is not free. It's prepaid through taxes and then rationed through time. Regional inequalities. Not all Canada is equal where you live, shapes your experience. In some urban centers, you might find world-class hospitals and a dense network of specialists. In smaller cities, rural towns, and northern communities, access to basic services can be challenging. Fewer doctors, fewer clinics, longer travel distances. That creates a quiet geographic inequality. The same country, the same universal system, very different realities. A parent in a big city might wait months for a child's assessment. A parent in a rural area might wait longer and drive hours each way to get there. Again, this isn't about blaming individuals. It's about capacity distribution. The system has a brand, universal equal access. But the map tells a more complicated story: infrastructure and outdated design. Walk through many Canadian hospitals and you'll see it. Buildings from the 1960s, 70s, 80s, patched and modernized, but still sitting on old footprints. Wards crowded with beds in hallways during peak times. Equipment rooms squeezed into corners. Limited isolation capacity for infectious diseases. Emergency departments trying to do far more than they were ever built to handle. At the same time, medical technology has advanced. More imaging, more lab tests, more minimally invasive procedures, more digital records, at least in theory. But physical space hasn't always kept up. And digital systems, when poorly integrated, can add new paperwork and inefficiencies instead of eliminating them. The result is a system where people are working extremely hard in spaces that were not designed for the volume and complexity of today AS cases. It's like running modern software on an old computer. It can work, but it lags, freezes, and crashes at the worst times. The mental health gap. Then there's mental health. The original healthcare model focused heavily on physical illness and acute events. Over time, awareness of depression, anxiety, addiction, and trauma has grown, but the system's capacity to treat these at scale has not always matched awareness. Many Canadians rely on limited public mental health services with long waits, pay out of pocket for private therapy if they can afford it, rely on basic coverage through workplace benefits, which may not be enough for long-term care. So even though the system is universal in principle, some of the most life-shaping conditions, those that affect mood, thinking, and behavior, can fall through the cracks. This has an economic dimension too. Untreated or undertreated, mental health issues reduce productivity. They increase disability claims. They strain families and communities. Again, the illusion is comprehensive coverage. The reality is selective capacity. Act 3, the economic bill. Productivity, quality of life in the future. So far, we've looked at how a system tailored for a younger, simpler world is now carrying an older, more complex one. Now we need to ask, what does this mean for Canada's economy and future? Health as economic infrastructure. Think of the healthcare system as infrastructure, like roads or ports. If hospitals, clinics, and preventive services are congested and under-resourced, it's like having traffic jams everywhere. People can't get from sick to treated efficiently. Conditions worsen while waiting. Interventions become more complicated and expensive. More people exit the workforce temporarily or permanently due to health issues. More caregivers, often in their prime working years, reduce their hours or leave jobs to support children or aging parents. Businesses lose productivity, projects delayed, sick days increased, experience lost. The middle class feels this as missed opportunities. Income that could have been earned but wasn't. Savings that could have been built but instead pay for coping mechanisms. A strong healthcare system is not just a moral good, it's an economic multiplier. When it works well, it supports growth, innovation, and resilience. When it strains, the costs are subtle but huge, the quiet cost to families. Consider a few quiet realities. A worker postpones a needed surgery due to wait times, living with chronic pain. Productivity falls. A parent spends months trying to get a child assessed for learning or developmental issues. During that time, the child struggles in school and the parent's work suffers. An adult child spends hours each week managing appointments, medications, and daily needs for an aging parent while trying to keep a full-time job. Each case alone is manageable. Multiply them by millions of people. Now add the stress of not knowing when help will come or if it will be enough. The original promise of universal health care was to protect families from the financial shock of illness. In the 21st century, the bigger threat for many families is the time and uncertainty costs of delay and scarcity. The fiscal question, can the model keep up? Healthcare is one of the largest items in any provincial budget. As populations age and expectations rise, spending tends to increase faster than general economic growth. This raises uncomfortable questions. How much of future tax revenue will be absorbed by healthcare alone? Will there be enough left for infrastructure, education, innovation, and other pillars of prosperity? How do you balance short-term pressure, fixing emergency problems now, with long-term investments, prevention, digital integration, training more staff? Again, you can approach this without politics. This is not about which party or ideology is right. It's about the shape of a system that is being asked to do more for more people with more complex tools than ever before. The original mission versus the new mission. The old mission was, no one should go bankrupt from basic medical care. The new mission, whether the system admits it or not, is keep an older, more complex population healthy enough to live long, productive, dignified lives. That requires strong primary care to catch problems early, sufficient specialists in diagnostic capacity, integrated mental health support, support for caregivers, modern facilities, and digital tools. A workforce that is large enough, rested enough, and supported enough to function. In short, capacity aligned with today's reality, not yesterday's. If the model doesn't evolve, the illusion deepens. Coverage exists on paper. Capacity struggles in practice. People's lived experience drifts further from the promise. What would a real healthcare success look like? Without getting partisan or prescriptive, we can describe a direction rather than a blueprint. A healthcare system that matches Canada's aspirations would make it reasonably easy to attach to a primary care provider, keep waits for critical diagnostics and surgeries within clear, safe timeframes, offer timely, accessible mental health support, protect healthcare workers from chronic burnout, use data and digital systems to reduce duplication and paperwork, not increase it. Plan for demographic reality, more seniors, more chronic illness, more demand. Economically, that would mean fewer preventable hospitalizations, more people staying in the workforce longer, less productivity lost to illness and caregiving strain, more predictable public spending trajectories. It wouldn't be perfect. No system anywhere is, but it would be honest. The illusion would give way to a more realistic, transparent understanding of what the system can and cannot do. Final thoughts. Pride versus complacency. So where does that leave you as a viewer and maybe as a patient? It's important to hold two ideas at the same time. The idea of universal access to medically necessary care, regardless of income, is one of the most humane concepts modern societies have produced. That idea, by itself, does not guarantee that the system has the capacity to deliver timely, effective, comprehensive care in a 21st century context. You can be proud of the principle and still critical of the execution. You can defend the core values and still demand that the system evolve to match the world it now serves. If you're watching this from Canada, here are 3 questions to reflect on. Have you, or someone close to you, delayed seeking care because you assumed it would be too hard to access or take too long? Have you lost work, sleep, or peace of mind because of waits, uncertainty, or caregiving responsibilities? Does your lived experience of the healthcare system match the story you were told about it growing up? If the answers feel uncomfortable, you're not alone. The illusion only works if people don't talk about the gap between myth and reality. The more that gap is mapped, described, and understood, the closer Canada gets to a system that's not just free in theory, but functional, resilient, and fair in practice. If this breakdown helped you see the issue more clearly, share it with someone who still thinks it's free, so it must be fine. And in the comments, keep it respectful and nonpartisan. What province or territory are you in? What has your experience with the system been, good and bad? If you could change one thing about how it works today, what would it be? Because in the end, healthcare is not just a policy, it's the infrastructure of your life. And illusions, no matter how comforting, can't substitute for capacity forever.